Good afternoon. My paper is a real-world data on progression of diabetic retinopathy. We started the study with the aim to look into the changes in best corrected visual acuity, diabetic retinopathy stage, and treatment approaches between the baseline visit and the follow-up visit. All adult patients who presented at Amrita Institute of Medical Sciences, Kochi, diagnosed with diabetic retinopathy and gave consent to be a part of the Government of India BIRAC registry were taken into this study. It was a cohort study of 493 patients over a duration of 24 months. At baseline visit, the visual acuity and stage of DR were documented. In patients with proliferative diabetic retinopathy, FFA, and followed by intravitreal injection of anti-VEGF agents and pan-retinal photocoagulation was done. In patients who had vitreous hemorrhage or tractional retinal detachment, pars plana vitrectomy was done. At the end of 2 years, we again looked into the visual acuity, diabetic retinopathy status, and the interventions that we did over the 2 years. The patients who failed to comply with all these advices were called, they were explained the need for compliance, and the reason for non-compliance were documented. Baseline data was of 493 patients. We had 146 females and 347 males. 70% of the population was in the age group of 45 to 65. And the sight-threatening DR, that includes proliferative diabetic retinopathy, lasered PDRs, and diabetic macular edema were the majority, which was 529. And at the end of 2 years, we noted that 194 patients were adhering to follow-up. Again, 65% was males, 67% was in the age group of 45 to 65, and less than 20 years of diabetic mellitus in 72% of the patients, which was similar to the baseline data. By the end of 2 years, around 60% have remained stable, but 40% had progressed with vision-threatening changes and needed active intervention. When we looked into the visual acuity change, it was seen that at around 1 year, there was a slight drop in the visual acuity, but by the end of 2 years, we were able to reach a visual acuity that was slightly better than the baseline visual acuity. As a subgroup analysis, when it was checked, the treatment naive PDR showed a progression that 30% was progressing to vitreous hemorrhages or tractional retinal detachments. In status post vitrectomy patients, at the end, in the first year, 66.7 had a stable or improved visual acuity, and by the end of 2 years, 70% could preserve their vision. So as I have told, we had called these patients and taken up the reason why they were not complying. They gave multiple reasons like difficulty in traveling, financial issues, systemic illness. One eye already lost, so they didn't want to progress for come for the treatment of the other eye, and various such reasons which we thought is important to look into. Coming to the discussion. 43.9 presenting with the treatment naive PDR significantly points out the need for more screening and public education programs for diabetic retinopathy. 40% progressing to vitreous hemorrhage or tractional retinal detachments, that they are the vision threatening complications, indicating that we need to have a faster pace because diabetes mellitus and diabetic retinopathy is progressing at a faster pace, so we should also buck up. 80% of the study participants have benefited from the treatment, 57% had experiencing stable visual acuity, and 22% having an improved visual acuity, underscores the effectiveness of the interventions implemented. And patient compliance, the reluctance to accept the poor prognosis nature of the disease and the long duration of treatment and follow-up is pointing at the ignorance among common people about diabetic retinopathy. This was not just the situation in India alone, but Ramaswamy et al. Did a study, and he found that patients were cognizant about diabetes mellitus, but understanding diabetic retinopathy and its implications were poor. Multiple studies internationally in Austria and all, they tried to negate the financial issue by providing them insurance, but still the compliance was less. So the limitation of this was the high attrition rate in the number of people who came for follow-up, and we did not, the multiple confounding factors like ocular diseases, systemic conditions, and other ocular interventions or medications that could not be eliminated completely. Concluding, regular follow-up and timely intervention significantly improved the visual outcome of 80% of our study participants. 40% progression of diabetic retinopathy shows that the vision-threatening nature of diabetic retinopathy warrants a close follow-up of the patients. To tackle diabetic retinopathy, a personalized approach is needed to educate the population about the sight-threatening nature of DR, the irreversibility of the damage, and the ideology behind the treatment strategies that we are advising. With the development of social media and artificial intelligence being incorporated into medical sector, we can improve patient education, compliance, and monitoring. Thank you.
Nice, madam. But you told patients are didn't come for follow up because they lost one eye. I do not know the reason.
Sir, actually, I personally had called and talked to these patients. So, one eye was tractional retinal detachment, and the other eye was severe NPDR, for example. So, the patient considered one injection or one sitting of laser as a treatment that is over. They didn't want to come for the next follow-up. They were like, I have already taken treatment in the one eye, why, and nothing happened, no changes there. I lost my vision. Why should I come for the next eye and spend my money? That was the question I had to face.
That means some counselor should have been there, then they can advise.
Sir, each of these patients, because for this registry, we had explained to them that they have to comply, they have to come, and this is a long-term disease. Everything was explained to them, but maybe the age of the patient, like elderly patients, are reluctant to understand the debilitating disease. Maybe that is one of...
One more thing, your slides, you're writing so many sentences in single slide is not something not attractive.
Okay, sir.
And moreover, all in block letters, capitals. You're not supposed to. It looks doesn't because slides also carry marks here.
Okay, sir. I'll make the changes.
Thank you.
Thank you, sir.